Respected seniors and dear colleagues, on behalf of International Society of Manual Small Incision Cataract Surgery, I, Dr. Anil Shah, President for Maharashtra chapter, welcome you, all the delegates, speakers, discussant on this wonderful series of webinar that is A to Z of Manual Small Incision Cataract Surgery. Today is episode 13 and the topic for today's discussion is Nucleus prolapse in anterior chamber, optimizing surgical success. The aim of our webinar is to popularize smart SICS. It should be safe, cost-effective with minimum learning curve, and it should be useful for community basis. In SICS, the mastery of nucleus prolapse defines the quality of surgical outcome. Precision and patience are cornerstone of effective nucleus prolapse in small incision cataract surgery. Each step in nucleus prolapse requires meticulous attention to the details to ensure the best of outcome. Learning each case strengthens the ability to handle even the most challenging surgical scenario. Excellence in SICS is achieved through continuous learning and dedication to patient care. These are the various photographs demonstrating how the nucleus is prolapsed into the anterior chamber. For this topic, we have Chairperson Dr. Prakash Marathe, Dr. Parikshit Gupte, Dr. Rajesh Joshi. And to highlight this topic, that is nucleus prolapse in the anterior chamber, optimizing surgical success, we have speakers who are expert in their field with the best of their knowledge and experience, Dr. Rohit Rao, Dr. Samir Gade, and Dr. Deepak Megur. The discussion for this topic, who will argue, debate and dialogue, Dr. Mandar Paransve, Dr. Anand Pangarkar, Dr. Usha Jori, and Dr. Shekhar Paransve. I am really thankful to all the speakers and discussant for giving their expert opinion, knowledge, and sparing their valuable time and making this webinar a grand success. Thank you.
I'll hand over to Dr. Aarti.
Yeah. Good evening, everyone. I, Dr. Aarti Heda, National Coordinator of ISMSICS, welcome you all on behalf of ISMSICS to this wonderful evening of learning. It's an honor to introduce the core team members of ISMSICS. We have with us Dr. Amulya Sahu sir, who is founder chairman of ISMSICS. We would like to hear some words of wisdom from Sahu sir.
Hello, can you hear me?
Yes, sir. You are audible.
Yeah, there is nothing much to see. I think Anil and his team, they are doing a wonderful job. And it's a really a good series for learning those who want to learn SICS. So I wish the web series to be successful. Thank you.
Dr. Jagannath Boramani sir, who is executive chairman of ISMSICS. We have with us Dr. Parikshit Gupte sir, who is vice chairman of ISMSICS. Over to you, Parikshit sir, for a few words.
Dr. Anil Shah sir needs to be congratulated for breaking down a surgery into so many multiple small parts. So when we see cars racing, and in racing cars, when they go to a pit stop, in that few seconds, there are so many things that are done. So in a small incision surgery, which an excellent surgeon may take just 5 to 10 minutes, there are so many multiple steps that are happening. And Dr. Shah has seen to it that each and every step is broken down and is explained differently by different surgeons. And along with expert surgeons, he also, finds little jewels, people who have been doing great surgery, but who have not had the chance to present. So this time we have Dr. Gade and Dr. Rao. It's an excellent initiative, and all of us in ISMSICS are very proud about this. Thank you.
Thank you so much, sir. Dr. Sitanshu Mathur, sir, who is Chief National Coordinator, Dr. B.K. Nayak, sir, who is President of ISMSICS, and Dr. Deepak Mishra, sir, who is Secretary of ISMSICS. Maybe they'll be joining us shortly. So we have with us Dr. Sanjay Tekavade, sir, who is practicing ophthalmologist from Pune. He'll be moderating the session with me. So over to you, Sanjay, sir.
Yeah, thank you, Dr. Aarti. I'll be sharing my slides. Okay. Yeah. Are my slides visible?
They are, sir. You can just go on the slide.
And I'm audible also, right?
Yes, we can hear you.
Yeah, okay. So let me start with introducing our chairpersons of Maharashtra chapter. Dr. Prakash Marat, we all know, he is the chairman of Maharashtra chapter, and he's also active in IMA as well as AIOS. And he'll be there with us today. Yeah. Okay. Yeah. Then we have Dr. Anil Shah, who's been doing an excellent job. All his seminars, webinars have been very appreciated by each and every one. He is an innovator. He has devised his own technique of small incision cataract surgery. He has also published books, and he also does demonstrations of his procedures. I think he's been invited to the States also. Then we have Dr. Parishit Gokte, who is actually one of the pillars of this ISMSICS. He is the vice president of this ISMSIS, and he also is very much active in AIOS as well as Maharashtra State Ophthalmic Society. Dr. Rajesh Joshi is the professor and head of JMC Akola, active member of, again, JCOR, AIOS, Vidarbha Ophthalmic Society, and also he was the secretary of Maharashtra Ophthalmic Society and Vidarbha Ophthalmic Society. Welcome, Dr. Rajesh. Our speakers today, who really we need to know, Dr. Rohit Rao, he, after doing his graduation from Wardha and graduation from Mysore, he did a fellowship in Arvind, Coimbatore, and then he was a consultant at Sri Ganesh Nayak Hospital, Raipur. He is very much active on his YouTube channel, and I am sure we'll have a feast of surgical videos and presentations from Dr. Rohit Rao, and we have a lot to learn from this presentation today. We have Dr. Samir Gade, who is from Nagpur. He has done his fellowship in glaucoma medical retina from HUDSI. He is very much active into myopia control. And again, he is into premiumization of ophthalmology. That is one part which you all miss. So we're looking forward to hear from you. And we have Dr. Deepak Megu. I think he must have joined by now. Deepak is an innovator. At the same time, his videos are famous worldwide, and we all have been learning from it. For his achievements, I think last year ACS, he got the best video. Also, he is the recipient of CS Rashmi Award, and he is one of the best teachers as far as surgical videos go. So with this, I hand over to the speakers to start their presentations. Thank you.
Sanjay sir, before we move forward, I have to introduce the Maharashtra chapter office bearers. We have with us Dr. Prakash Marathe sir, who is chairman of Maharashtra chapter. So over to you, Marathe sir, for your comments.
Yeah. Thank you, Dr. Aarti. Good evening, everyone. On behalf of Maharashtra chapter of ISMSICS, as chairman of Maharashtra chapter, I welcome all of you for this wonderful webinar, which has been organized by our president, Dr. Anil Shah. I think it is a small incision topic, but the webinar is not that small. That series is big, and bigger and bigger. So many things are there. Though the surgery is small incision, the topic is very long. And nobody can elaborate so many things. And it is only Dr. Anil Shah who could do it. Today's topic is very important. That is about the nucleus delivery. Handling the nucleus in SICS is the great step. It's the main step. I think there are so many steps like scleral tunnel, and then in CCC, and then handling of everything. But then nucleus delivery is the very important thing, which keeps the media clear, and that's the way the person can have vision. So removing the nucleus is very important, and that has to protect the corneal endothelium, that way not to disturb even the vitreous. And delivery of nucleus is very, very important. We have got the experts here who will be elaborating on this particular topic. Persons and discussants, they will give their inputs also. With these words, I hand over to Dr. Aarti and all the team to take it forward. Thank you. Thank you so much.
Thank you so much, Marathe sir. Other office bearers of Maharashtra chapter include Dr. Anil Shah sir, who is president, Dr. Mandar Paranspe, who is vice president, Dr. Amay Kulkarni, who is secretary, Dr. Usha Johri ma'am, who is joint secretary, and Dr. Anand Pangarkar sir, who is chair of scientific committee of Maharashtra chapter of ISMSICS. We have with us Dr. Usha Johri ma'am. Ma'am, would you like to say something? Yeah, so till the time ma'am is coming back, let me just call upon our discussants for this session. Dr. Usha Johri ma'am, Dr. Mandar Paranspe, Dr. Anand Pangarkar sir, and Dr. Shekhar Paranspe sir. So without further delay, we will start with the academic talks. So I invite Dr. Rohit Rao sir to please start his presentation.
Thank you, Aarti. Hope my presentation is visible.
It is visible and you
Yes,
are.
yeah.
Thank you, Dr. Anil sir, for this opportunity. I would like to thank ISMSICS for this wonderful opportunity to me. So let's dive into the topic given to me, that is step-by-step guide to nucleus prolapse. So before we go into the details of the topic, I would like to highlight some concepts, which is the rhexis size, hydrodissection, nucleus edge, idea of nucleus edge, and viscoinjection. These concepts have to be clear before you proceed with nucleus prolapse. So as you can see, for this Hulk, the door is very small. He cannot pass through that. So we have to understand, if the door for the nucleus, that is rhexis, if it's small, there will be complications. We will not be able to bring the nucleus out safely. So if the door is very big for the Hulk, the nucleus can easily come out. Like you can see in this picture, the rhexis size is adequate and the nucleus can easily prolapse out of the bag. So commonly what traditional teaching tells us is to hook the nucleus out of the bag. So in this hooking, we traditionally go to the edge of the nucleus and gently hook the nucleus and then rotate in circular fashion and slightly rock it out of the bag. But personally saying, it's not my favorite technique because it has some drawbacks, which is if we are doing it blindly, you might risk injuring the rhexis rim or you can land up in zonular dialysis. My favorite technique is the hydroprolapse technique. In this, we are having a pushing maneuver. In this, the fluid wave comes inside the bag and it pushes the nucleus out of the bag. So here you can see the rhexis rim is being retracted and then gently the fluid wave will go underneath the nucleus and it will come out along with the nucleus. This technique is very safe, it's very fast and easy to master and learn. All the senior surgeons will do this technique to ease out the surgery. So I suggest everybody we should move towards hydroprolapse. Next is hooking the nucleus, epinucleus or surface of the nucleus. Whenever we are doing and trying to hook the nucleus out, sometimes we are very superficial and we are just scratching the surface of the nucleus, which will not let the nucleus come out. It is a strict no-no. So what we have to do is we have to find the edge of the nucleus and try to engage the edge and bring the nucleus out of the bag. Here you can see that the surgeon is trying to scratch the surface and he struggled. So he went deeper and find out the edge of the nucleus and tried to hook it out. So once the nucleus is hooked out, now the second part of the nucleus, which is on the left side, that has to be brought out. Here you can see what the surgeon is doing. he will go and scratch the surface. This kind of scratching of the surface will never lead to nucleus prolapse, successful nucleus prolapse. We have to go to the edge. So here you saw that he changed the position of the engagement of the dialer at the nucleus edge. So now, once half of the pole of the nucleus is out, then what we have to do is we have to inject some visco under the pole so that the nucleus stays out. Once the pole is out, it's very common that people tend to go it inside, push it inside. So to prevent from it to go inside, we have to put some visco just underneath the prolapsed edge. Here you can see that the surgeon is trying to do hydrodissection. We can see that the genital fluid wave is gone and good hydroprolapse has been happened. But you see where the visco is being injected. It is being injected above the lens. This kind of visco injection will lead to nucleus going inside the bag again. So what you have to do is, see here, I am doing hydroprolapse. Once the hydroprolapse is done, you can see that the nucleus visco is being injected just underneath the nucleus. This kind of visco injection will help us to keep the nucleus in the AC, not going into the bag again. So in this talk, I would like to address 3 problem statements which are commonly faced by any junior surgeons. So the number 1 is how to bring the nucleus pole out. As we discussed, you have to bring the pole either by hooking or by hydroprolapse. Here, this is the similar video where the surgeon is trying to hook. But you see what the pushing maneuver is happening. The dialer is using, but he is pushing the nucleus inside the bag and he is just scratching the surface. There is no proper finding of the edge. The surgeon is not able to find the edge. He is not engaging the edge, just scratching the surface. This kind of maneuvers will land up 100% in zonal dialysis or aphakia or very grave situation of nucleus drop. So then second question comes is how to prolapse the nucleus if it is come out from one side, either inferiorly or sideways. So let's see here, you can see that the nucleus has come out on the right side. So what I'm doing is I have injected already visco and I'm taking the dialer. I'm engaging exactly at the edge where it has come out and gently rotating it. This gentle rotation towards main port will help you to remove the nucleus. So once you have brought it towards the main port, then the things become easy because you can see the edge very clearly, you can engage the edge very clearly. Similarly, if the nucleus edge has come out on the left side, you can rotate in the other direction by just engaging at the edge and gently rocking it towards the right side. So this way, you can bring the nucleus towards the main port. Once the edge of the nucleus is out towards the main port, then it is very simple. Now the third important point is how to prolapse if the nucleus pole is out near the main port. So here you can see that the surgeon has already done hydroprolapse. He has injected visco. He's trying to prolapse the nucleus with the visco cannula. But you see what is happening? He just keep on rolling, and then this infinite roll can never end, and the other pole of the nucleus will never come out because he is not flattening the nucleus. So once the nucleus is prolapsed, either by hooking or by hydro, you have to inject some visco under the edge. After that, you slightly rotate it towards right or left and then try to flatten the nucleus in the AC. This kind of flattening of nucleus is the most important step to bring the other pole out of the bag. Here in this video, you can see that the one pole is being brought out. Once the pole is out, what surgeon do is they'll make it vertical. This kind of vertical making nucleus will be very difficult. Then we have to flatten the nucleus and make the nucleus flat on the bag. That's way we can bring the other pole out of the bag. So same thing we can see in the video. Here I have engaged at the edge. Gently I am rocking towards the left and then I am pulling it down. Gently rocking towards the left and pull down. So this way I am flattening it over the iris and the bag. This flattening is the most important step to bring the other pole out of the bag. Otherwise, we'll have that infinite roll video, which how we saw just now. So till now we discussed routine cases, what happens and how do you manage. One special scenario I would like to mention is hypermature cataract. Here, the nucleus is floating in a liquefied cortex. So what all conditions we have in a hypermature cataract is, one is it is a big nucleus. Second, we have a very liquefied cortex. So we have very poor support and poor visualization because of the liquefied cortex. So how do you manage? First is you need not do any hydrodissection because the nucleus is already free from the cortex. Then aspirate any liquefied cortex which you have, which is disturbing the view, and then proceed to a bimanual prolapse. A bimanual prolapse can be done either by using dialer or by using cystitome, according to your own choice. So here, first point I would like to highlight is that whenever you are doing a bimanual prolapse, a right-handed surgeon needs to go towards the left side corner. We have to have a secondary instrument in your non-dominant left hand and primary dialer or a cystitome in your dominant hand, and then gently hook the nucleus and immediately take the viscocannula or iris spatula under the nucleus. Here you can see same thing being done with the cystitome. You have to immediately take the viscocannula or iris spatula under the nucleus so that it does not fall back again into the bag. This way you can gently hook and you can try to keep the viscocannula and use it as a guide. It will prevent the nucleus from going back into the bag. So what all complication you can face if you are doing nucleus prolapse? First is the nucleus cheese wiring can happen. Then if you are not very careful, rhexis tear can happen. And in very grave cases, you can land up in zonular dialysis or aphakia. So take home message from my talk are: number one, adequate rhexis size has to be there. Number two, a good, very well hydrodissection is must. Second, you have to identify the edge and only engage the dialer at the edge of the nucleus, not the surface. Fourth is you have to inject some visco under the prolapsed edge. And fifth and last and most important is you have to flatten the nucleus over the bag. Thank you. Thank you for this opportunity.
Thank you so much, Dr. Rohit. Great talk, excellent videos, and amazing animations. So best part was that you showed both the wrong and the correct way of doing things. So next, we would like to invite Dr. Sameer Gade for his presentation. Over to you, Dr. Sameer.
Good evening, everybody. Thank you for this opportunity. Is the presentation visible?
Yes, we are good to go.
Yeah. So when I was given this topic, I was thinking to myself, kya hi instrument lagte hain? There is one Sinski hook, one viscocannula, one hydrocannula. What possibly more can one need to prolapse the nucleus? I mean, it has been ingrained into us over the years that I guess most of us are doing SICS mostly on a spinal level right now. But then it got me thinking that okay, there are a lot many things are going into are working in the back end which we haven't actually thought about it. So the first thing that I think before any kind of nucleus that you are trying to prolapse, first thing is important is you need good visualization of the rhexis is really important. So I always a firm believer that you should always stain the capsule, irrespective of the fact you have a good microscope, bad microscope, you should have a good visualization of the rhexis. Also, an adequate large size rhexis is really preferred in cases of nucleus sclerosis grade 3 and beyond. So this is like one of my most favorite instruments that we can use to prolapse. We use a hydrocannula. You can see the fluid wave going in, and then the one pole of the nucleus just prolapses out. Then you can use a Sinski hook to dilate out in this video. I think this is preferred by most senior surgeons, as Dr. Rohit was saying. It is very easy to use. It takes a little skill to learn. And I think in places of high volume surgery, this is the most preferred technique. Also, the same thing can be used in cases of mature cataract where the nucleus is a little soft. You have a lot of liquefied cortex. It just comes out. You just hold it and it comes out. This is another video which is on which only the Sinski hook can be used to dial the nucleus out. You just do a hydrodissection wave, it goes inside. Then on both the sides, you tap it, you pick a Sinski hook and you hook it out. Very simple process. You have to be, all these procedures can be done only in softer cataracts. So much of pressure applying on one side of the bag can be detrimental in hard cataracts. So a lot of people are also using Sinski hooks. Cystotomes. They just, again, it kind of embeds into the equator of the nucleus and then you prolapse it out. I find this a little dangerous for myself, but a lot of people who can control it, they're doing amazing work. This is another method which I've seen a lot of people do. They use an iris spatula, put it inside. I think Dr. Rohit has already shared these videos. You make sure that the iris spatula goes in and you rotate it over the spatula and it prolapses out into the anterior chamber. This is using only a visco cannula, a form of hydroprolapsing. You push one visco through one pole, dip it, and the other pole comes up, and then you dial it out. Really simple maneuver. I guess that just sums about it. Thank you so much for the opportunity.
Thank you so much, Dr. Samir. I should say that again, the excellent talk and great surgical videos. So let's invite our next speaker, Dr. Deepak Megur, sir. Over to you, Deepak, sir.
Yeah, thank you. Yeah, as has been told by Dr. Gade and Dr. Rohit Rao, I'd like to, the Dr. Rohit Rao just demonstrated beautifully the different ways of prolapsing the nucleus. Well, my favorite would always be the bimanual way. So the reason is, it is very versatile, and I want to ensure that that this is a technique which is reproducible in most complex case scenarios. Like, for example, you have a smaller rhexis, you have a weak zonules, where in those situations, using just a Sinski hook to dial out the nucleus would be risky. So I would insist that most beginners should learn the bimanual way of prolapsing the nucleus out. So here, what I'm using just two Sinski hooks. So one Sinski hook goes and hooks the equator of the nucleus, and it is under it, and then it's being rotated. You can use iris spatula or a visco cannula, as was demonstrated by Dr. Gade. But the idea is you need to wheel the nucleus out. So this is a much more safer and a predictable way to prolapse the nucleus in different case scenarios. With experience and with maturity, we would want to ensure that the rhexis size remains 5 millimeter or 5.5. See, if you want to prolapse it on its own, the only cliche is, you should have a very big rhexis. So with refining of your surgery, we want to ensure that the rhexis size is maintained at 5 or 5.5 millimeter. That is the ideal way to place the lens in the back, which ensures greater centration over a longer period of time. If you want to do that consistently, then you need to be skillful enough to remove the nucleus using whatever technique through a 5.5 millimeter rhexis. And that is, I feel, is more easily possible and predictable when you use the bimanual way. So this was my first remark, because many surgeons I see who come for training with us, they try to use a single instrument, and they get stuck in some complex situations. So moving on to the next situation scenario where, okay, we have a scenario where we are dealing with the hypermature cataract, a Morgagnian cataract. So here the challenge really is to first save the bag. When you're trying to prolapse the nucleus, there is every risk that you may the rhexis can run out, or you may just lose the bag. So in such situations, you need to be very mindful that before you reach to the stage of nucleus prolapse, you should ensure that your bag is still intact. In such situations, we may have to use the CTR quite early enough. And one way is, in hypermature cataract with loose zonules, it's important to put viscoelastic in the bag itself. That itself will spread in the bag and acts as an temporary artificial, zonule. So first want to, whatever the bag is empty, try to refill with viscoelastic. That provides some stability for you to attempt rhexis now. You can see there's a lot of wrinkling of the anterior capsule. The bag is just waiting to come out. So in situations, we want to save the bag by some way or the other. So if you can get a rhexis right, you can put in a CTR and the bag can be saved. But many situations will be such like this, we have a small speck of calcification, which prevents an easier tearing of the capsule. So you need to be as gentle, as careful as possible. And in this situation, again, go back and reform the bag with OVD. So at this point, the best would be to try to introduce a CTR. At least you can stabilize the bag at one end. But the situation here is we have a weak point. At this point, if you want to put in a CTR, you can cause a little bit of a problem. So insert the CTR first here and then consider enlarging the rhexis. Because if you don't enlarge the rhexis, again, the bag is going to come along with it. So you have to consider inserting the CTR before prolapsing the nucleus out, even though the rhexis is still not complete. Because you have so even with the rhexis being still incomplete, I'm just considering, trying to put in a CTR inside. So this point got me worried that, while putting the CTR itself, the rhexis should not run radial. So I'm trying to do the rhexis from the other end and try to see whether I can complete the rhexis. But unfortunately, this area was really weak and I had to cut it using scissors. So at this point, we have some sort of a semblance of a rhexis. It is still not very perfect, but at least I can have a situation where the ends of the rhexis, the capsular tear, are meeting. So we have a decent sized opening here, and the weak point is again here at the 6 o'clock position. This is where is my concern. And if I try to prolapse the nucleus out, there is every chance that the bag is going to come out. That is my major concern here. So you can see the inferior zonular dialysis is already there. So again, viscoelastic acts like a third hand. You should always, in this case, if you can use something like sodium hyaluronate, it's going to create space and maintain it there for some time. It's going to maintain it so that you can maneuver the nucleus and get it to the appropriate position. Using a cohesive OVD, it itself helps us. It's like an instrument itself. It can help us to stabilize the bag for a moment. And now, before prolapsing the nucleus out, I'm going to introduce the CTR inside. And the only worry for me is I have a suspicious area here where the rhexis might not be complete. But anyway, with the ring inside, the bag is very well stabilized. And now we can mobilize the nucleus out quite easily. So the take-home message from this case was, it is not, if at all you find the rhexis to be, difficult, you can always stop and try to introduce the CTR before even completing the rhexis. But in situations where you feel that introducing the rhexis, CTR itself can put the radial rhexis, make it radial, then maybe you have to complete it and then go ahead and put it. Second point is, don't hesitate to use the cohesive OVD, sodium hyaluronate. It really fills in the bag very well, and it's a secret. If you use it, if you use just HPMC, the moment you try to introduce, everything will come out. So it may not be finding it difficult. Even introducing CTR might be difficult if the AC shallows and the bag collapses. So using cohesive OVD does help you. So this is one situation, and let me take you to another scenario. So this is again a hypermature cataract here. So this is a case. Okay, this is the case here. Now, how do we plan surgery in this patient? Now, he's an elderly 80-year-old male patient who has pseudoexfoliation, non-dilating pupil, and hypermature cataract. See, the real challenge here is you need to deal with the pupil as well as have an adequately sized rhexis so that we don't cause intracapsular extraction. So zonular health is the primary concern here in these patients because of pseudoexfoliation, age, and also long-standing nature of the cataract. And second, density of the cataract is also quite significant. So you need to expect a slightly bulky cataract. So in such situations, what you need to have a slightly larger axis. Now, because in this case, the nucleus was quite dense, it was a conscious decision to do SICS and not do phacoemulsification. And what are the difficulties which we anticipate during this surgery? First of all, the pupil is small. So deal with the pupil first. So ISMSICS are the best way to deal with it when you're doing small incision cataract surgery, because if you use a pupil-based device, then while prolapsing the nucleus out, the device itself gets disengaged. And second would be to deal with the weak zonules. So you have to use some way to stabilize the bag before prolapsing the nucleus out. So that's the reason why CTR insertion timing becomes extremely important. So I prefer to, whenever in such cases, I would prefer to put the ring before prolapsing the nucleus out, as was discussed in the previous case. So let us go to the case now. Let me just go back, and once you have stained the capsule now. So we are going to use a dispersive OVD, and now this is the time. I would want to use a iris hook or a capsule hooks. In this case, I've decided consciously to use a capsule hook to stretch the pupil, because in the event of a weak zonules, and if I am required to stabilize the bag as well, the capsular hooks will come in handy. So that is the idea. So one trick here to when you're doing the stab incision is try to be very posterior limbal. Don't be near cornea, be most posterior limbal. The one which is subincisional has to be about 0.5 millimeter behind the scleral incision. So this is one which is going behind the scleral incision. And this is what I'm going to stretch the pupil. So we don't want to stretch it to the limbus, because it would create in a lot of tear the sphincter capsules. And once it is in place, I'm going to enter with my 2.8 millimeter keratome and make the incision. So the health of the capsule, anterior capsule, is really known only when we touch the capsule. So when you touch the capsule, you can see the bag is very wobbly. The wrinkles on the anterior capsule suggests that the health, the capsular bag is, the zonules are really sick in this patient. So this is a time when you have to be very circumspect. You have to use a very sharp cystitome to puncture. My forceps, I was unable to puncture it. And again, using a forceps is a good way to do rhexis in such eyes with weak zonules, because you have better control and you can tear the capsule without inducing much stress on the already weak zonules. And here, I would want to do an IOL trap wherein I want to have an optic capture, but at the same time, I want to have a decent rhexis size, because this is a dense nucleus. If I try to manipulate, then the bag itself might come out. So that is the situation. So again, hydrodissection is important in eyes with these weak zonules, but in mature cataracts, I usually avoid, but this is a special scenario where we are worried about the attachment of the bag. So again, the introduction of the CTR early enough is a critical factor. So this is a preloaded CTR which I'm using here. See, the timing of the CTR insertion is important. The maximum stress on the bag happens during the nucleus prolapsing out. So if you are able to stabilize the bag before the nucleus management, then you can really save the bag. So many times I go ahead and repeat hydrodissection after putting the CTR again. So that gives us a better way to loosen the attachments of the bag with the cortex and the nucleus. And once the bag is really free from its attachment to the capsule, that's the time when I go and use it. And again, these are situations where your bimanual way of maneuvering the nucleus out is helpful. My left hand is going to retract the rhexis margin out, and then gradually the nucleus is wheeled out of the bag. So let us just review this again in slow motion. The right hand dialer pushes the nucleus down and away from me to the right side. The left hand goes beyond the rhexis margin, hooks the equator, goes under it, lifts it gently, and it just stay there. And my right hand instrument comes in. Again, I have to disengage the nucleus from the bag. Then only it's easier for us to prolapse the nucleus. without pulling out the bag along with the nucleus. So you need to be this is possible only because I am able to see well. In a small pupil, I would not be able to see well, and I would have just wheeled the bag along with the nucleus. So the first step is, you need to see well. To do that, you have to dilate the pupil using these hooks. And once the nucleus is out of the out of the bag, it is very much easier for us to prolapse. So the take-home message from this is, in difficult situations, ensure that you see well. Don't hesitate to use iris hooks or capsule hooks, and stabilize the bag before trying to prolapse the nucleus out. So that was it. Thank you for your attention.
Thank you, Dr. Deepak. That was an excellent presentation. I now invite the discussions of today, Dr. Usha Madam, Dr. Paransve sir, and Dr. Pangajkar sir. Let me start. All throughout the presentation, we saw that one of the most important point is the size of the capsular axis. Now that we are getting trained in like phacoemulsification, the size of the capsular axis is going down. And we also say, okay, 5.5 is ideal. But as we saw in most of these cases, we get the nucleus out in toto, undivided. So the size of the capsule has to be very perfect. Otherwise, most of the complications are related to the size of the capsular axis. Like inadequate capsule will cause zonular dialysis, it might cause PC rupture, it might cause the nucleus to drop. So I would just want the panel to highlight on this as to how do you decide the size of the capsular axis. We saw Dr. Deepak demonstrating beautifully, but then many times the nucleus is so hard, so large, and so undivided that sometimes it's not possible in a small axis. So how do you decide on the size of the axis? Dr. Usha, ma'am.
Maybe Anand sir has raised
Dr.
his
Shekhar Parajpe. Okay.
Anand sir has raised his hand.
I can add something there. Yeah, I can add something there.
Yes.
Yeah, I am predominantly into a anterior chamber maintainer during capsular axis also. So in this situation, whenever we feel like capsular axis is extending peripherally, you can stop and you can bring it inside. If you feel that it is little getting shorter or capsular axis opening is little less, you can enlarge it. So those who are not using anterior chamber maintainer during capsular axis, they can have definitely try over it. In only trick in this is that instead of using 20 gauge MVR blade for the capsular axis, you use 23 gauge MVR blade, or enter with the 20 gauge MVR blade and don't enter fully, so that your chamber maintenance is good. The fluid doesn't leak out from the sides of the capsule, your 26 gauge capsulotomy needle. Your chamber is very much deep. You can increase the bottle height to anything up to the ceiling also. And then you can do very comfortably capsular axis, a bigger capsular axis also. With visco, I always find the capsular axis opening is little smaller than what it should be for the SICS nucleus prolapse. I think I have made it little clear, isn't it?
Yes.
The concept, what Dr. Rohit has suggested, the concept of nucleus edge is very nice. Once you can locate the nucleus edge, bringing out the nucleus is very easy. Second thing, what he has suggested, once you have seen the nucleus edge, you inject the visco not into the AC in front of the nucleus, but behind the AC, behind the nucleus. By that, automatically what happens, the nucleus starts prolapsing little easily. Samir has suggested to use trypan glue in all cases. This is a good idea, but I doubt whether all senior SICS surgeons will accept to this. Because what we, as Rohit has suggested, what we require is to see the edge. Once the edge is visible, definitely your nucleus is away from the capsulexis border, in front of the capsulexis border, and then rotating it out is very easy. I have so many things to talk about, some objections about Deepak's talk. One question I have really for the Deepak is how you control your non-dominant hand when you go behind the nucleus. One hand is behind the nucleus, maybe spatula or maybe another hook, but there is always clear in many surgeons' mind, at least in my mind, that my hook may rub against the posterior capsule and it will damage the posterior capsule. Deepak, can you add on to this?
I think he's not there.
Sir, I think Deepak sir has left. Maybe he
Left.
might.
Okay. So anybody,
I think
you
such surgeons are gifted that their both hands are dominant.
Sir, actually, what I do is I put a spatula, not a hook. You put an iris suppositor or a spatula. So a spatula normally would not damage the posterior capsule. So behind you put a spatula, and on the edge of the capsule you use the iris, your hook, Sinski hook. So the spatula goes behind.
Dr. Deepak is here.
I think Deepak is here.
Dr. Deepak now. Yeah.
Yeah. Deepak sir, did you get the question?
Deepak, I have asked that how you use your non-dominant hand to go behind the nucleus. Because I always fear that my the non-dominant hand may touch the posterior capsule or it may poke the posterior capsule and it will rupture. So, do you have anything to add?
No, sir, it is not so difficult at all. You can maneuver it quite easily, sir. It's not such a thing. The only thing is in Karnataka, we have been taught like that only. So we have to thank our mentors, Dr. MS Ravindra and Dr. Sundaram Shetty. So from day one, we have been taught just like that. So we never found it anything unusual at all. So we find that is the way to be done. So we thank our mentors for that.
Yeah.
So, and if the bag is completely filled with visco, then the chances of rent are much less.
Okay. Okay. One objection about Rexis and CTR. Deepak, are you hearing it? No?
Sir.
Yeah. Out of 10 or 12 cases of CTR which I have used in case of pseudo-explanation or the cases like this, my observations is that all capsule, IOL and CTRing all prolapses all 6 into the vitreous after 2 to 3 years or 5 years. So instead of that, my logic of putting the CTR is just to stabilize the capsular bag. But in such situation, instead of putting the IOL in the bag, I would prefer to put in front of the capsule, out of the bag. So
that's what we are doing now, sir. That's what we are doing now, what we call as the IOL trap technique, where the haptics are placed in the sulcus and the optic is placed behind the bag. So we have CTR in the bag and the optic of the lens inside the bag, but the haptics are in the sulcus. But the important thing here is we need to use an hydrophobic 3-piece lens. That really helps us better rather than using any other lens, because the hydrophobic material holds the capsule together. It is adhesive to it. So this has ensured better results than putting everything in the bag.
Anyway, even if you are putting the optics in the bag and haptics outside the bag, after a few days, the capsule will push it out and the lens will be outside the bag only. So it is your just satisfaction that you have put the IOL in the bag. Once the capsule contracts, that optics will come out of the bag. Definitely. Take it from me. Hope I am making it clear, because there is no support of the haptics to keep the IOL in the bag. Haptics is already out. Both the haptics are already out. So little more contraction or even squeezing of the eye, probably I think, or pressing the eyeball from one side or the other, the optics will come out of the bag. That is for sure.
I think this is the topic for Dr. Deepak for his publication, next publication.
Okay.
No, sir, I have done a study I've been doing this technique for the last 8 years. I have presented
It
this
remains in the bag.
many conferences. I have a long-term study of about, say, 55 eyes now with this technique. And I have been following for last 6 years. And in my study, nothing has come out, sir. None of the optics have come out, or none of them, the entire bag has not gone behind. So this is my experience.
Okay, very good then. And one more last suggestion, or maybe a question, you can take it as you want to. When there is a difficult capsular axis, and you feel that the nucleus is much bigger than the capsular axis opening, you just, as for the episiotomy, when the head is big, they cut do the episiotomy. The same way, I give multiple cuts on the capsular bag, and then the nucleus just pops out of the capsular bag, and then after cortical aspiration, I implant the lens outside the bag. So that is easier. Only thing is that instead of whatever power is you have calculated for in the bag, 1 to 1.5 after less of power you have to put outside the bag, isn't it? Because using extra skills and then creating problem, instead of that you create a problem in such a way that you have got no option other than to bring the nucleus out with a big capsular axis opening, as in the olden days we used to do can opener capsulotomy. In those situations, nucleus just pops out of the capsular bag because there is no CCC. It is wiser thing to do instead of causing posterior capsular tear or causing capsular avulsion from the zone.
Regarding this, yes, sir.
Yeah.
Yes,
Add anything on this?
Yeah.
No, I have completed my talk.
Yeah.
Regarding this relaxing incisions, I think two circumferential incisions sometimes help. They do not extend to the posterior capsule. At the same time, the force is divided equally. Yeah, Dr. Usha, madam, you wanted to say something?
Yeah. Very good evening to all of you, and thank you, Dr. Anil Shah, for having me here. I would just like to say, Dr. Anil Shah ने बूंद बूंद से पूरा घड़ा भर दिया है. हाँ, अभी 1-2 बूंद सर बाकी है, वो भी मेरे को लगता है 2-3 सीरीज में पूरा हो जाएगा. I think you have done an excellent job.
10-15 बूंद बाकी है.
सर फिर बाद में भी आपको छोड़ेंगे नहीं.
Okay.
We will ask for
और एक पूरा घड़ा बाकी है.
Second घड़ा बाकी है, sir. Sir, I know all three of us, no doubt about it. That was an excellent presentation. Dr. Rohit Rao, I just wanted to ask your experience about, cataract, where, you, I think, couple of times mentioned about the scratching the surface. Did you ever have any incidents where, while scratching, the nucleus, was broken or cut into pieces, It's just a question. I think it's a very theoretical question, but this is what, I thought of asking you. The second thing is, for the benefit of the youngsters, I would like to, ask you, good hydro means what? How much fluid you would be injecting? And whether it's 0.5 cc, or how do you assess how much fluid has to be injected? I think it's a very, very practical question, and you see and then you inject. I understand that, but just for the benefit of youngsters, this is one question I would like to ask. And of course, Dr. Deepak Megur, there is nothing to be asked, because he's so brilliant, in his presentation, so clear in his talk. One thing that I wanted to discuss about Dr. Samir Gada is probably one instrument that you probably missed out, or maybe you didn't feel important, was, a vitrectomy. Supposing there is a problem, whether the vitrectomy machine has to be kept ready or not, that is probably you might have missed out, or you might have felt that it's not important, So these are my simple, suggestions or questions, whatever you may say. And, thank you very much, So,
ma'am, regarding the first question, whenever I'm teaching my fellows, sometimes I've seen the epinuclear bit or the cortex is disturbed, which causes the view very hazy. but I have not seen nuclear piece getting broken, or sometimes broken nucleus is seen while bringing it out of the eye while delivery. That I have seen multiple times, but not while prolapse into the AC.
This could happen
And,
especially when the nucleus is very soft, isn't it?
Yes, yes,
The
yes, ma'am.
contact is very, very soft.
Yes, yes, yes.
No, I mean, just, you know.
And
how much
regarding,
fluid?
yes, regarding the hydro, as our eyes are inside the microscope, it's very difficult to judge 0.5 ml or 10 ml or 2 ml. So what we have to do is 2-3 things we have to keep in our mind. Number one, when the cannula goes inside the capsular bag, we have to tilt the cannula such that it lifts the capsule out away from the nucleus. That way, we create a plane between the capsule and the cortex. That plane, and in that plane, if we inject, we do a cortical cleaving hydrodissection, which is very easy, very helpful in later stage of the surgery. And in a softer grade cataract, we will see the fluid wave passing. And as the fluid wave passes, you have to continuously keep a watch on the fluid wave. As it reaches the edge, you have to see the nucleus popping out. If we do not see that, that means that our hydro is not proper, or some issue is there. We have to address that. That is in clear media. If we have a opaque media, wherein you are doing a mature cataract or brown cataract, at those cases, first of all, our hydro should be slightly suboptimal than normal. And whenever we are seeing, we'll see slight shallowing of the AC, or the lens will be becoming slightly up. It will come up, and that up movement is the end point of hydro. We cannot say in mLs actually.
Yeah. Yes, Dr. Palansi, sir.
Yeah. The question is for all the three speakers plus all the experts here. I have done this procedure only in 2 or 3 cases. It is not fine-tuned with me right now. But the thing which I do whenever it is difficult to bring out the nucleus from the capsule bag, use of reverse Sinski in one hand and use of standard Sinski hook in another hand. Reverse Sinski hook goes behind the nucleus, but that the tip of the hook is not pointing downwards towards the posterior capsule. It is pointing upwards towards the cornea, and then on the surface of the nucleus, you use a hook, and then you can bring out the nucleus easily. So instead of using a spatula or say another hook in a left hand, if you use a reverse Sinski hook, which is especially used for the endothelial dissection, that may help. Once or twice I have used it. I haven't fine-tuned the technique because I didn't find it necessary to use it. But those who find it difficult to bring out the nucleus, use of reverse Sinski hook in another hand may be a good help. Any comment or any suggestion, or has anybody tried something like this?
Sir, I think what we saw in Deepak sir's video, he's using 2 Sinski hook only while doing his bimanual prolapse of the nucleus. If I'm not
but I am suggesting that is correct. But I am suggesting in one hand reverse Sinski hook, so that tip is always pointing forward.
सर नॉर्मल को ऐसे घुमा दिया ना तो तरी होऊन जाईल ना सर.
Yes, Dr. Shah, sir. Yes.
I think you
unmute yourself. Dr. Shah, sir, please unmute yourself.
All these things I have got an answer. Can I share my one presentation of new instruments so that all these questions will be solved?
Yes, yes.
Sure, sir.
Yes, sir, yes. Yeah.
Sure, sir.
Yes.
This is it visible?
Yes, your presentation is visible, sir. Yeah.
And voice is there?
Yes, we can.
Dear colleagues, I am Dr. Anil Shah from Suryakant Eye Hospital, Nandurbar. Today I am presenting ballpoint multi-purpose intraocular manipulator, a new device. This ballpoint manipulator has got many advantages. It is used to prolapse the nucleus from the capsular bag without damaging posterior capsule or capsular ring to reposit iris prolapse in the wound and in the side port incision. It is least traumatic to intraocular structure. One can manipulate IOL in the anterior chamber, and there are many more advantages. Dear colleagues, I am Dr. Anil Shah from Suryakant Eye Hospital. In this video, I will demonstrate a new instrument, ballpoint multi-purpose intraocular manipulator. This is the multi-purpose manipulator which has got a ball tip. It is a smooth tip. These are the indications which are useful for this instrument. Now, after hydrodissection and hydrodelineation, the nucleus is prolapsed. One pole of the nucleus comes out of the capsular bag with the hydrodissection. After that, the HPMC is injected below the nucleus so as to make a space in the capsular bag. Now this ballpoint manipulator is passed below the nucleus and it just rotates below the nucleus and lifts the nucleus from the capsular bag into the anterior chamber. This ballpoint doesn't cause any damage to the capsular ring or even to the posterior capsule. Now this is another case. Here the Sinski hook is used to nudge the nucleus and the ballpoint goes behind the capsular ring below the nucleus and lift the nucleus from the capsular bag. During this maneuver, it doesn't cause any damage to the posterior capsule or even to the capsular ring and even to the intraocular structure. Again, HPMC is filled to make a space in between the nucleus and the capsular bag, and this ballpoint manipulator is nudged to the edge of the nucleus and the nucleus is prolapsed into the anterior chamber. This is very safe instrument to prolapse the nucleus without causing any damage to intraocular structure. Thank you. This is the new instrument which I have developed, and I think this is helpful. It won't cause any damage to posterior capsule or even to the capsular ring, and easy manipulation and prolapse of the nucleus into the anterior chamber.
Very good.
Yes, sir. It's very good, sir.
One
important
comment on this also, no problem.
Well, sir, very nice technique, sir. One important question that Dr. Usha ma'am just raised was soft nucleus. Sometimes it's difficult to prolapse a soft nucleus out of the capsule because most of these maneuvers, when you try to either rotate or spin it out through a Sinski hook, it just goes through it because there's a hold on it. So we all have experienced soft nucleus. You try to do something, the instrument just goes through it. There's no hold on that nucleus. So, ma'am, the best technique here would be hydro expulsion. You just keep on doing injecting fluid within the capsule, and the nucleus will come out. Because if you try to do any of these maneuvers, it will not hold.
One comment about not related to this, but one of the speakers' presentation there was mention about the fish hook technique. I think the real fish hook technique I have seen in one of the live surgeries few years ago. It is done by doctors at Lahan Hospital, Nepal.
Lahan Hospital, Nepal.
And you really cannot see that technique. It is so dangerous to see that the cornea, endothelium, everything is worried about that. What you tried to show one of the presenters, I think it was not the real fish hook technique.
It wasn't, sir. It wasn't.
Real fish hook technique is very difficult.
Very dangerous.
What those people say that it is very nice in their hands. Yes. Probably the results what they expect they may be getting, but you just cannot see that procedure.
I have one question for Deepak, sir. Actually, so you mentioned that we are all as the technology is progressing, we are all striving to have a 5.5 millimeter axis. That is what our aim should be in, because we are able to implant good lenses, we should have an adequate cover. But how do you go about looking at the rexes when you have a lens thickness of more than 5 millimeters? I've seen one of your videos, you often talk about oval rexes, and if you could just pass some comments about that thing.
Dr. Deepak sir, you have to unmute. Yeah.
I think oval rhexis was first popularized by Dr. Daljit Singh's son, Kawaljeet Singh, if I am not wrong.
Kiranjit Singh.
Kiranjit. It's a good technique.
Yeah. So oval rhexis is specifically I prefer to use in posterior polar cataracts. Okay. So in posterior polar cataracts, most often what happens, the posterior capsular tear happens when you want to maneuver the epinucleus out of the bag, and the subincisional epinucleus is the most difficult thing to manage. So that is where all the problems happen. So oval rhexis is specifically used for the posterior polar cataracts. I have not used it for any hard cataracts. But for most cataracts, if you're with reasonable experience, by 5.5 you can manage. But again, we have to be sensible also when the situation is very tough. When dealing with a very bulky nucleus and a black nucleus, then we have to compromise on the saccharorhexis because we need to save the bag first. So a little bit of a common sense does help, but with skill, I think we can manage to do SICS with in a 5.5 millimeter axis in most case situations.
Thank you so much, sir. Actually, just off the topic, I have actually managed to train myself and be a better surgeon with torsional phaco just by watching your videos. So thank you so much for having the YouTube channel.
Thank you. Thank you so much.
Sanjay sir, should we take comments from our chairpersons?
Audience. Yes. Or are there any questions from the audience?
Sir, not yet. We will just check the other platforms as well.
Yeah.
Meanwhile, we can take comments from our chairpersons.
Yeah.
We have with us Dr. Prakash Marathe sir, Dr. Anil Shah sir, Dr. Rajesh Joshi sir, and Dr. Parish.
I think there is some connectivity issue.
Yeah.
With Dr. Aarti, what she has recently.
Yeah, I think Dr. Marathe, you can start.
I think it was a wonderful webinar. Nucleus handling in case of small incision cataract surgery is the important step. And what three presenters, they showed their videos. Those were wonderful. And the way various procedures were shown, especially Dr. Deepak Megu's videos, they were fantastic. And there were so many things to learn for the youngsters as well as general ophthalmologists who have been doing this small incision cataract surgery. And even discussion on those topics is going on very well. And it is a wonderful discussion amongst all of us. Hope all participants, those who have joined online, are enjoying this. I think other people like Dr. Shiri Sura, then Dr. Rajesh Joshi, they need to talk something. Dr. Rajesh, are you there? Yeah, please.
Yes, in fact, it was a wonderful webinar. I thank ISMSICS for giving me this opportunity. All the presentations were wonderful and great, and the videos were really wonderful. But as far as my experience goes during teaching as well as learning small incision cataract surgery, I find two situations which are difficult in prolapsing the nucleus. The one is the very softer cataract, soft variety of the cataract, particularly having a posterior subcapsular opacity with some nuclear grade of cataract. And the second one is the Morganian type of cataract with small rhexis. Of course, rhexis itself is a difficult proposition in Morganian cataract. In first situation, like softer variety of cataract, I do multiple hydrodissections. And what happens if when you do multiple hydrodissection, loose cortex comes out, and removal of nucleus in this softer cortex is very difficult. So you may have to aspirate the cortex off and then prolapse the nucleus out of the bag. The second condition is the Morganian cataract. Dr. Deepak has beautifully shown the use of two lens hooks. In fact, I use wire vectors just behind the nucleus and then Sinski's hook in front of the nucleus to prolapse the nucleus out of the bag. I think all the presentations were wonderful. And I thank ISMSIS, MSICS, particularly Dr. Anil Shah, for giving this opportunity. Thanks. Thanks a lot.
Thank you so much, Rajesh sir. So,
if I may just add that the videos for the presenters was excellent. The use of animation was fantastic. If there is one tip that we can give to all the viewers is that we should keep the anterior chamber as much formed or deep as possible when we try to prolapse the nucleus into the anterior chamber. So either that can be done by liberal use of visco, or it can be done using an AC maintainer. But once that's done.
Thank you so much, Parikshit sir. We have with us Dr. Taswala sir and Dr. Sirish Thorat sir, if they wants to comment anything.
And it was fantastic. I've been following Dr. Deepak Mego's videos also on the YouTube. He gives excellent tips. The good part here, I would like to say regarding the soft nucleus, what Tekavre also said, hydro expression is the best way to do it instead of fiddling with any of the instruments, where we are very likely to land up with a PCR. That is one. Second is for the Morganian cataract also, we need to have a buffer of visco in below while extracting the nucleus. Very important to create space while you're trying to negotiate the nucleus out of it. Fantastic videos and fantastic animation. I loved it attending this session. And a very good innovation by Dr. Anil Shah, where he was my CR. So I know his capability, the way he does. He has got a mind with creativity. Great going, Anil.
Thank you. Thank you.
Yeah. Sirish.
Dr. Sirish is there. Yeah.
Sir is probably muted. So do we have any other comment from... yes, Dr. Rohit, over to you.
I have one question. What I face sometimes in my OR, if I have a posterior polar cataract, what traditional teaching says is we should avoid hydrodissection and we should do only delineation. And then the removal of epinucleus is like nightmare. So what I do is I do hydrodissection like normal. And if there is a PCR, and then I go ahead and manage it because I have made a good rexis. So if some experts can comment on how to go about it, it would be very helpful.
I have certain tips. What you can do is, instead of doing a proper hydrodelineation, you do it by little bits of bouts, about 0.1 cc, 0.1 cc in multiple areas, other than going through and creating a wave inside. So that really helps in separation of the epinucleus very well.
Okay, sir.
Controlled hydrodissection can be done under visualization.
Yes, absolutely.
If you're not visualizing, then you should not attempt.
Yeah, multiple attempts should be done rather than a one go.
Okay.
A lot of surgeons are also proponents of viscodelineation and in cases of posterior polar cataracts, as you said, sir. Rather than hydrodissection, you have a visco wave which passes through, which can be controlled a little bit better.
Yeah, what Dr. Rohit's problem is, 1 minute. Because, yes, sir. Yes, Paranspe sir, yes.
Yes, Shekhar sir.
Yes, Paranspe sir.
Comment to make.
The point which I am going to put is little out of the box thinking. It might be that somebody must have tried it also. As we do for phaco, there is something like pre-phaco chop. We make the 4 pieces of nucleus in the bag only. And once you make 4 pieces of nucleus in the bag, can we bring out those 4 pieces one after another into the AC so that final incision size of SICS will be also less, and bringing out of the nucleus, we are bringing small pieces of nucleus into the anterior chamber. Has anybody given thought to it, or is it just out of box thinking? I haven't done this ever because I don't do pre-phaco chop. But has anybody tried like this in our audience also, or in the panels also? And if not, can we go with the message that something like this can be tried? all
Sir,
our
we
three
have the
speakers.
pre-chopper in, we can divide the nucleus in the bag itself. So
Yes,
usually
and then bring it
dividing
out.
this into two halves, we'll give a nucleus about say 3.5 to 4 millimeter. So you can get a 4 millimeter nucleus out. You don't have to make 4 pieces. 2 pieces in the bag itself, you can remove it out.
Okay. Two pieces. Has anybody tried something like this?
Yes, sir. It is there.
Have you tried this like
Yes,
this?
sir. Yeah, I've tried and many
Great.
videos are there. Sir.
Great.
Okay.
Sohail Khan has the
The
pre-chopper.
snare is there, which is we divide in the antechamber. And the pre-chopper, we can divide it in the bag itself.
Good.
So what happens if you make too many small pieces? Sometimes getting them out becomes difficult because what you're trying to do is build up pressure inside. So if the piece is small, then many times the pressure doesn't get built. So I think 2 would be.
2 pieces are sufficient for almost all cataract.
And regarding Dr. Rohit's query about managing post-polar cataracts, I think, even if you don't do hydrodelineation also, it is okay you bring the nucleus out. For removing the epinucleus, you have to use viscodissection. You have to use viscodissection. And in this situation, if you have a slightly oval rhexis, which the longer meridian is in the subincisional area, and if you use viscodissection from the side port to float it up, then you can easily maneuver it passively out of the bag and then out of the eye. Okay.
Sir. Thank you.
So you don't have to induce PC tear just because you want to, you're so scared to remove the epinucleus. It is possible to do that also. The size of the rhexis is, you have to understand, in these situations, the rhexis is the main hindrance for us. So when you create a very small rhexis, the epinucleus, removing the epinucleus becomes very much issue. So in this situation, if you make an oval rhexis, at least in one pole, you have an access to push something to float up the epinucleus. So that is the idea of using this oval rhexis.
Okay, sir.
Sanjay sir, do we have any more comments?
Yeah, I think there's no questions on the other platform also. So I think Dr. Aarti, you can summarize and conclude.
Yeah, so before I give vote of thanks, I would like to make a small announcement that we have.
Or ISMSICS, everybody is requested to register. All faculty, all office bearers, everybody is registering. So you are requested to register and tell your colleagues because there are limited number of registrations. Maybe up to 200 maximum registration will be allowed. So very less time is remaining. So participate in that particular great event. All are requested to join. Thank you.
Thank you, Anil sir.
Thank you very much. Thank you very much,
Thank
everyone.
you, Doctor, all the
It's a nice
chairpersons
presentation,
and
nice
speakers.
webinar.
Yes, sir. Thank you.
Thank you, sir.
Nice
Thank you,
presentation
ma'am.
and webinar
Good
also.
night.
Thank you, sir. Thank you.
Thank you.
Thank
Good night.
you.
Thank you.
Thank you, Rohit.
Good night, everybody. Thank you
Yeah.
for the
Thank you,
opportunity.
Paranspe, sir. Yeah.
Thank you, Megul sir.
Thank you,
Megul
Deepak.
sir. Thank you, sir.
Yeah. Thank you.
Thank you, Sanjay.
Thank you, sir. Thank you for this opportunity.
Permission to leave, sir.
Yes, permission to leave for all. Thank you,
Thank you.
Samir.
Thank you. Good night. Thank
Good
you.
night, sir.
Okay,
Thank
good
you.
night,
Yeah.
sir. Good night. We'll leave the meeting. Thank you.
Yes. Thank you, sir. Thank you.
Rahul,